So welcome everybody. I think we are ready to start. Can I have my slide on, please? Yes. So welcome to the Updates in Heart Failure 2025. I'm Gianluigi Savarese. I lead heart failure and arrhythmia research at Karolinska Institute at the South General Hospital. It's a pleasure to welcome you in Stockholm. And you are here, but we have also many participants who are online. So more than 10,000 colleagues are actually following us from all over the world. This is the third time we meet for this meeting, and I really do hope we will see each other also next year, just before Christmas in the lovely Stockholm. The meeting is organized by Karolinska Institutet and the South General Hospital here in Stockholm, and I will start to thank very much TMA, which took care of setting the logistics for this meeting. Many faculty colleagues coming from US, Canada, and Europe. So, you know, it's a big organizational effort. I would like also to thank all the sponsors which actually made this possible. Without them, this will not just be feasible. And say that, I would like to ask the head of Department of Clinical Science and Education at Karolinska Institutet, Professor Melian, to just give some words for greet you. Thank you.
Thank you, Gianluigi. It's a great pleasure to also welcome you from my behalf, from the department, from the Karolinska Institutet, Stockholm. Apologies, we can't offer you Stockholm in winter colors, but nevertheless, I wish you really two fruitful and scientifically fantastic days. Last week, we celebrated the Nobel Week and the discoveries that led up to the Nobel celebration and awards. Let's continue the discovery, the science, the collaboration, the international network. I am pleased to see so many international guests here today, but also to extend the discoveries into clinical science. And I'm very glad to see that this is about implementation in clinical practice. I'm a pediatric allergist, pediatric pulmonology myself, so this is a bit outside my field of expertise. Although, again, don't forget that children also one day become adults, and the early origins of disease is important also for the adult heart failure, I believe. So with that, I welcome you. I wish you two really fruitful days. I want to thank Gianluigi and the team and the department for the organization and the funding and the sponsors, of course. So with that, welcome and good luck with the meeting.
Thank you so much. And just a few words also from Professor Hoffman, who is actually head of education and research at the South General Hospital. Robin.
Yeah, thank you very much. I'm very excited to be here. Together here with my colleagues who will introduce themselves very soon. We are very proud to have so many international experts here in Stockholm, and from the Department of Cardiology at the Södersjukhuset. I extend my gratitude for you coming and joining us in this busy time of the year. So most welcome.
Thank you. Just 1 second before we start the session. The first session will be on translating guidelines into practice, status of barriers and strategies to foster GDMT implementation. And since we really want to be on time, and I will really invite all the speakers to be in time with their presentation, which is 10 minutes, in order to have a very fruitful discussion. And say that, I just leave the words to the chairs of the meeting.
And by that, we kick off our first session, as Gianluigi has just presented. I'm chairing this together with Robin Hoffman. My name is Camilla Hage. I'm from Karolinska University Hospital in Stockholm. And as co-chair, we also have on screen Professor Agarwal from India. And
Riccardo Inciardi. Good morning, everyone, from the University Hospital of Brescia in Italy. It's a great pleasure to chair this session. Camilla, please.
Yes, and then we introduce our first speaker, Felix Lindberg. and he will talk about the gap between what guidelines say and what physicians do, the status of GDMT implementation worldwide. Please.
Thank you for the kind introduction, and thank you to Gianluigi and TMA for organizing this event. And especially thank you for letting me to go first before the other distinguished speakers have set the bar too high. So it's my task to give an overview of the current state of implementation of guideline-directed medical therapy for HFrEF. And I would like to start off by just acknowledging that we're talking about a syndrome where 1-year mortality is still approximately 24% 1 year after diagnosis, and that the available core pillars of pharmacotherapy have an estimated accumulative benefit corresponding to a number needed to treat of just about 4 for preventing a death at 2 years. And this stark need for treatments is contrasted by what we see in real-world registries. So here we have registries from North America, Europe, and Asia showing that under-implementation is a pervasive issue across regions. Although most patients receive beta blocker and a RAS inhibitor, only 30 to 60% receive an MRA, and of those patients who are on treatments, a minority receive them at target doses. And similarly, this has been the global phenomenon has been reported by Report HF, including 18,000 patients from across 44 countries, showing that the lack of implementation is really a global issue, extending across country income levels. Now, these data that I have just shown you predate the 2021 guidelines and the introduction of quadruple pharmacotherapy for HFrEF. And they also predate the transition in the adopted approach from a conventional sequential approach to a parallel initiation and titration of pharmacotherapy. And now we have some more recent data here from the Titrate HF study from the Netherlands, including approximately 4,000 patients between 2022 and 2024. And now this is a registry setting and a rather well-resourced setting, but following the adoption of this parallel approach. And they showed in Titrate HF a slightly higher adoption of quadruple pharmacotherapy than prior studies. Approximately 44% of patients prescribed quadruple pharmacotherapy. But even in this registry and well-resourced setting, only approximately 1% received 4 drugs at target doses. If we now look closer at the registry we have here in Sweden, the Swedish Heart Failure Registry, zooming out a bit, comparing where we were some years ago to where we are now, we can see some progress. On the left-hand side, we can see between 2003 and 2012, there were limited or no improvements in the adoption of heart failure therapies. And following 2016 to 2023, we have seen an uptake across all drug classes over time, particularly following the 2021 guidelines, rapid adoption of SGLT2 inhibitors and quadruple therapy reaching approximately 60% by 2023. And similar findings have been reported from the Norwegian Heart Failure Registry, improved implementation across drug categories following 2021. And these observations are by no means causal, but I think it's interesting to note that the periods where we have observed improved implementation in Sweden, Norway, we have also observed improvements in heart failure outcomes. To the left, we have decreasing numbers of heart failure-related mortality in the general Swedish population, and to the right, decreasing heart failure hospitalizations in Norway. This study from last year in JAMA Cardiology tried to put a number on the evidence implementation gap on a global level. They tried to quantify the potential impact of optimizing GDMT to all eligible patients worldwide, and they estimated that approximately 20 to 25 million patients with HFrEF were eligible for GDMT, but also that there was substantial underuse. And incorporating real-world event rates and the efficacy observed in trials, they estimated that globally and on an annual level, approximately 1.2 million deaths could be averted by moving from the current implementation to one where all eligible patients receive GDMT. So what are the potential reasons for why we do not achieve GDMT in our patients? Last year, we published this survey where 400 physicians, slightly more than 400 physicians, got to list the barriers that they viewed as most clinically important for the underuse of GDMT. And not surprisingly, clinical barriers linked with poor tolerability or contraindication of GDMT, such as hypotension, renal disease, and hyperkalemia, were among the most common responses as barriers. But when we look at actual registry data from the real world, where we try to map out the actual reasons observed in registries, these clinical factors appear to explain only a minor part of the underuse that we observed in registries. For example, from HELP-HF, we can see that approximately 55% of patients underdosed with MRA had no apparent clinical reason to do so. And similarly, from Titrate-HF, documented side effects and intolerance appear to explain less than a third of non-use of GDMT. Another frequently cited barrier was patient adherence. But here, if we look at the EPIC-HF trial, where they collected reasons for non-intensification of doses during the trial, the combined proportion of missed non-intensifications due to patient adherence and patient preferences appear to account for 2% or less. And clinical inertia was a much more prevalent reason. So there appears that other factors must be part of the issue. And here we see a cross-center variability in the use of GDMT across different studies. To the left here, we have from Titrate-HF, the across-center variability in the achievement of quadruple therapy, which was 25% among the lowest centers and up to 75% in the most successful centers in achieving GDMT. And from SWEDHF, we have observed very similar numbers across the centers reporting to SWEDHF. And this observation that some centers appear to do very well in implementing and other centers appear to do much less well appears to suggest that organizational factors must play a role. And a critical organizational factor playing a role appears to be the access to dedicated cardiology and heart failure resources. In Titrate-HF, patients treated in a dedicated heart failure unit were much more likely to achieve quadruple therapy. And similarly, in SWEDHF, we have observed that follow-up in a specialty unit compared to primary care is independently associated with higher use of GDMT. So where do we move from here? I think the issue of implementation is growing increasingly important and also increasingly complex, with an increasing number of evidence-based therapies that should and can be offered to patients. And this development is likely to continue into the future. And this development places a greater need for implementation science to better understand how we can translate the therapeutic advances into real-world outcomes. Now, the solutions to improve implementation are unlikely to contain a one-size-fits-all solution, but rather different approaches must be used in different clinical scenarios and different healthcare systems. And some of these tools were outlined in a position paper published last year from the HFA on how to address clinical inertia in HFrEF. But I think that two common broad strokes appear as likely factors that could improve implementation across many different settings. And those are improved access to cardiology resources and cardiology care and cardiology follow-up, and also improved implementation of real-world registries that are live databases that can serve as monitoring tools for monitoring the actual implementation, and also for platforms for either screening for under implementation or for conducting implementation science studies. Thank you.
Thank you. Thank you very much, Felix, for a very elegant presentation. For the sake of time, we will move on. And as Gianluigi pointed out earlier, we will have a common discussion at the end of the session. So now I'm very happy to announce another very well-known heart failure specialist, Professor James Burton from the University of Leicester. Welcome. Thank you very much for coming.
Thanks, Robin. So I'm the nephrologist in the room, And I've got 10 minutes to tell you everything about what Felix mentioned, which was about CKD being one of the barriers to GDMT. And Robin even said, if you could do it in less than 10 minutes, James, that would be absolutely fine. So I've got some declarations. But look, this is from the AHA presidential address. I'm sure you've all seen it. And I use it to highlight just how aware we are becoming of the crossover of cardio and renal and metabolic disease. And we shouldn't need guidelines or statements to tell us how important it is to work together in that field to make sure that we optimize outcomes for people with heart failure, CKD, and metabolic syndrome. But nevertheless, it has been highlighted. And I'm going to come back to this, and it's an absolute privilege to be here as a kidney doctor, talking about how we can collaborate. And I'm going to get you to reflect on a couple of things, I hope, from my view as a kidney doctor. And one, this is from KDIGO, it's our international guideline group, and I've just highlighted at the bottom, I'm going to read that out. Use the same principle in people with CKD to diagnose and manage cardiovascular disease and atrial fibrillation in those people who don't have kidney disease. So why do I highlight that? I highlight that because people with kidney disease are treated differently. They are treated differently. This busy table is from the MyNap database in the UK of 300,000 people who were treated for a non-ST elevation MI over 15 years in the UK. 10% of them had CKD because that's the prevalence of CKD. And so this is a comparison of how those people with CKD were treated against those people who didn't have CKD. And you may say to me, well, of course they're treated differently, James, because they might get contrast. Well, we could talk about that. But look at every single one of those treatment options is different between those two groups. And these data are from 2024, I think, based on that. It's in the last couple of years. This isn't about whether they had a big dose of contrast for their stent or PCI. This is about whether they are discharged on aspirin or not, or dual antiplatelet therapy, or whether they get a beta blocker or a statin. People with kidney disease are treated differently. And it is a huge barrier to GDMT. If we can't give people aspirin and a statin after a heart attack, then what are we doing for GDMT in people with heart failure? So my question was to think about what are the barriers to that? Well, one is around creatinine. So I'm sure you've all been in that situation where people come in with heart failure and they're diuresed and their creatinine goes up and the diuresis is weaned back. Well, this is just a reminder that actually this is survival for people with heart failure. And people who leave hospital who are congested with a raised creatinine do badly. People who leave hospital without congestion and with a normal creatinine do the best. But in between that, it is better to leave hospital without congestion and not worry about the creatinine than it is to worry about the creatinine and they leave hospital with congestion. Does that make sense? Because those people who are congested would do worse. So if we focus on their creatinine and we withhold important treatments, those people will die sooner than if they didn't have CKD. The same is true for ACE inhibitors. The STOP ACE trial, which looked at the use of ACE inhibitors in people with GFRs of less than 30, we know from a kidney point of view that it will not accelerate or indeed slow down their progression to kidney disease. It is safe to continue from a kidney point of view, but those people who need those medications for heart failure are then not prescribed them because we have a culture, a thought that ACE inhibitors in people with reduced kidney function is somehow not good for their kidneys, that they are nephrotoxic. And that is just not true. That's a terrible terminology. And that's the outcome from the STOP ACE trial. No different from a kidney point of view, but important from a heart failure point of view. And we also know that if we think that we're doing someone a favor by giving them 2.5 milligrams of Ramipril or 25 milligrams of Losartan, we are just not. It is much the same as being on a low dose as being on no dose. And you can see that there for people who are on, whose RASI therapies are stopped versus those that are continued at full dose and those with a down titrated dose. So look, RASI therapies are important, really strong evidence base. We know that. We should be continuing them at the highest approved dose. And yet, the creatinine is a significant barrier to that. So I'm going to show you the most recent guidelines for heart failure from NICE in the UK from September of this year. Look at that at the bottom. If a creatinine increases by more than 50% of all their potassium concentration goes to above 5.5. I am sure many of you would have thought that the raise in creatinine would not be as high as 50% to be of concern. It's just something to bear in mind about our practice. Okay, hyperkalemia. I just want to mention that we've got some talks coming up about hyperkalemia. It is a barrier. And we often down titrate the RASI doses. We think 1.25 milligrams of Ramipril is better than nothing. It's not. And we do that because of potassium. So I highlight this from KDIGO just to say, if you look at the middle column, hyperkalemia, there are many steps that we do, including the use of potassium binders well before we think about down titrating disease-modifying medications. And that is important because we know that it works. So this is a meta-analysis of the use of potassium binders and optimization of RASI therapy in people with CKD or heart failure. And you can see that actually optimization of RASI therapies across a number of different trials, if people are on potassium binders, their RASI therapy will be optimized. So first of all, we've got to get them on, as Felix said, we've got to make sure they're on their GDMT. But potassium binders will definitely optimize RASI therapy. They definitely reduce the risk of hyperkalemia events, and we've got more talks about that. It definitely standardizes and brings potassium into the normal range and optimizes their use of GDMT with no signal of increased adverse events versus those not taking potassium binders. I've got 2 more slides left and 2 more minutes, so I'm doing very well. Robin is smiling at me. To just come back to this idea of really working together on this. I'm sure many of you will be doing more cardiorenal metabolic clinics, and there is absolutely no doubt that having the expertise of different specialties with different lenses in the room brings added confidence in managing those people with diabetes and heart failure and CKD that so often coexist, and using the individuals that we have, whether that is specialist nurses, pharmacists, or doctors. So I'm going to just mention one thing about an integrated, I absolutely accept what Felix said about the access to specialist advice and knowledge, because I don't think it needs to be access in a specialist clinic. It's access to that specialist advice and knowledge. And what this graph shows is the prescribing of finerenone in GP practices who have access to us in an integrated care setting. And I say us as nephrologists. And this was published just last month. So this is the prescribing of GDMT, specifically in finerenone for the management of CKD, in those primary care networks where they have regular monthly meetings with a nephrologist. And you can see in orange, so yellow are those GP practices in Leicestershire without regular access to that, and orange is the national average. So there is no doubt that that access to specialist knowledge increases confidence and increases GDMT. So just to remember, so people with CKD are treated differently, and we need to get past that, focus less on numbers of creatinine and potassium and more on solutions, which I know we're going to talk about. And the best way to do that, I think, is to have more things like this and more opportunities to work together. And I'm going to stop there.
Thank you so much. Perfect.
Thank you, James. It was very great presentation, and we actually touched the point that we are going to discuss in the next presentation. And I'm very pleased to present Gianluigi Savarese that will talk about hyperkalemia as a barrier to treat patients with heart failure. Please, Gianluigi.
Thank you so much. And as already been introduced by the previous speaker, this is a very important topic. Hyperkalemia is indeed one of the major barriers to the implementation of GDMT. You see that is very prevalent in patients with cardiorenal metabolic disease. And another very important point is it's recurrent. It means that patients go through several episodes of hyperkalemia, and together with increasing number of episodes, also the time between one episode and the other becomes shorter. So that's an important topic to be discussed in the setting of GDMT implementation. There are some subgroups of patients who do have higher risk of hyperkalemia, and these are definitely patients with heart failure and patients with CKD. And the risk increases together with more severe CKD and more severe heart failure. And patients with diabetes, of course, have also increased risk of hyperkalemia. And we see that patients receiving specific GDMT, such as, for example, MRA, RASI, have higher risk of hyperkalemia, of course, due to the fact that these drugs affect the metabolism, the homeostasis of potassium. But whereas some factors, some risk factors are irreversible, we cannot just remove heart failure, CKD, or diabetes. Some are reversible, such as CKD, such as RASI use and MRA use, but we should consider these as irreversible as well, because whether we do actually withdraw this medication, we increase the risk of mortality and morbidity in these patients. So do not consider RASI and MRA use as actually reversible, but irreversible risk factors for hyperkalemia. And you see that this condition is very heavily associated with increased risk of mortality. So it's something we really need to learn how to handle in our clinical practice, with an incidence of any hyperkalemia event in patients with heart failure across the ejection fraction of around 25%. So that's a very important and to keep in mind. But part of the fact that hyperkalemia is linked with increased risk of mortality is not due to hyperkalemia per se, but is due to the fact that because of hyperkalemia, we might withdraw GDMT, which we know very clearly impacts prognosis. So we should keep this in mind, that probably by withdrawing medication, we actually harm the patients more than actually keeping them more than hyperkalemia per se. And this is a very important, according to the physicians, barriers to the implementation of GDMT. We investigated this in a survey we performed 2 years ago with the Heart Failure Association of the ESC. And you see that according 45% of the physicians who were actually surveyed, hyperkalemia was one of the major barriers to the implementation. You see also that the first reaction of physicians to hyperkalemia in many cases was withdrawn of RASI and MRA in a very high number of physicians, so over 55% of physicians were actually reducing dose of MRA or withdrawing the treatment. Very few used K binders. And you see that actually physicians were reacting even to potassium levels over than 5, which might highlight even some overreaction to the problem per se. So whether withdrawal of MRA is frequent in patients with hyperkalemia, the other problem is that in a majority of cases, they don't get reinitiated when the episode is over. And this is very nicely shown in this slide, reported to be associated with very much increasing risk of mortality, which strengthened the message I provided earlier, which is part of the risk which links hyperkalemia to mortality is due to the fact that patients withdraw GDMT. And how to handle hyperkalemia? First of all, we should focus on patient profiles and the fact that different treatments have different pharmacological properties. And we should also keep in mind that some of the GDMT we use are not associated with increased risk of hyperkalemia, and therefore in some settings should be prioritized. First of all, don't forget that whether you use sacubitril/valsartan as compared to ACE or ARB, this is associated with less impact on potassium homeostasis. And as shown in the paradigm-HF, use of sacubitril/valsartan was working even as an enabler for MRA use. SGLT2 inhibitors in the EMPEROR program was linked to less discontinuation of MRA, likely mediated by the fact that the risk of hyperkalemia was reduced. And don't forget also that in patients with worsening heart failure, where you have a clear indication for vericiguat, actually vericiguat will be safe in terms of potassium levels because they are not impacted by this treatment. And beyond focusing on patient profile, you should keep in mind that novel K binders have strong evidence supporting their use for optimization of GDMT use and handling of hyperkalemia. These are the key trials I'm going to present in the next very few minutes. This is the harmonized trials, patient randomized to SGC, different doses. You can see that in patients with hyperkalemia during 44 hours, actually the drug was successful in leading the potassium levels to normokalemia. Then at that point, patients were randomized to SGC or placebo, and you see that those randomized to SGC were able to stay in normokalemia range levels of potassium in the long term. So this is one of the two key treatments we do have in terms of novel K binders for treating these patients. And if we go to patiromer, the second novel K binder available, these are the results of the Amethyst. You see once again that there was a decrease of potassium levels linked with initiation of patiromer, and which was sustained over the time. And when the drug was withdrawn, actually there was an increase of, again, potassium levels. So these are treatments which need to be used in the long term. When it comes to other evidence supporting the use, we here have the results of the Diamond trial, which indicates that the optimization of RASI is possible even in the setting of hyperkalemia. So indeed, in this trial, enrolling patients with a FREF, potassium level were reduced by patiromer as compared to placebo. And very importantly, you see very clearly that those randomized to patiromer were able to maintain, more likely to maintain MRA target use. They had lower events in terms of hyperkalemia, and they could achieve more likely GDMT, higher GDMT use. The second key trial has been the REALIZE case study. This is on SGC. It included 2 cohorts of patients, one with potassium level between 5 and 6 and eGFR more than 6, and they were initiated or up-titrated with spironolactone, and whether they developed hyperkalemia, they were actually started with SGC. And there was also a second cohort. These were those on normokalemia at high risk of hyperkalemia, they were initiated or up-titrated with spironolactone, and they were randomized to SZC or placebo, whether actually there was hyperkalemia developed. And major outcomes you see reported here, assessed at 6 months, were to stay on potassium level between 3.5 and 5, being on spironolactone at 25 milligrams or higher, and not using rescue therapy for hyperkalemia. So you see that the primary outcome was met with SZC as compared to placebo. You see also that the secondary outcomes were met, so there was actually less incidence of hyperkalemia in patients randomized to SZC, and less likely discontinuation of spironolactone because of hyperkalemia. The results were even stronger in older patients and in patients with eGFR less than 45, where the risk of hyperkalemia is even higher. There was a numerically higher risk number of events in terms of cardiovascular death or worsening heart failure in those who were on treatment, but there was also an imbalance in baseline characteristics in the two arms, which might explain that patients on SZC were sicker and therefore also at higher risk of developing hyperkalemia. Current guidelines recommend actually novel K binders in patients with potassium over 5 in order to optimize GDMT treatment. And this is just to conclude. Don't forget that hyperkalemia is not a topic typically of nephrologists or cardiologists, something that all physicians should enter in their when they meet the patients with hyperkalemia. Treatment with RASI is definitely a reversible risk factor for hyperkalemia. We should not withdraw this treatment. Whether a patient has an hyperkalemia event and this is and the risk of hyperkalemia is high, so there is no reversible cause for hyperkalemia, we should consider novel K binders for actually keeping patients on GDMT. Whether they are on novel K binders, there will be no need for additional potassium monitoring. Thank you very much for your attention.
Thank you very much for this slightly long but very nice talk. We will move on to the next barrier, which is hypertension, and we welcome Nicolas Girard from France on stage.
Thanks a lot. It's a pleasure to be here today. So I will cover low blood pressure in this talk. Sorry. Okay, is low blood pressure a problem? So this is my breakdown. For sure, low blood pressure in acute heart failure is associated with outcome, and it has been known for many years. But when you look at the dynamics of blood pressure, for sure, you have a huge increase of baseline low blood pressure with worse outcomes. But changes in blood pressure during the follow-up is nowhere near as much associated with outcome. And if you compare the association of stopping GDMT treatment with outcome, you're far higher with stopping drugs versus just having some blood pressure variability during follow-up. And so we try to address that in the SWEDHF registry, and I thank a lot the SWEDHF team letting me do this analysis within their major registry. So almost 50,000 patients with FRF, and for sure, low blood pressure is associated with outcome, but it's not really what's of interest to you as a clinician. Indeed, low blood pressure is less associated with outcome with higher dose of GDMT, right? So again, baseline low blood pressure is bad, but yeah, low blood pressure and the high level of GDMT is not as bad. And when you look again at the dynamics, when you decrease your blood pressure while increasing GDMT, tada, neutral association. So really keep this in mind in your practice. And if you break down further, according to GDMT level and blood pressure, and you can create some scenarios. So what would you prefer? Having SBP of 135 with less than 50% GDMT, so that's the red one, or 110 with 100% GDMT. So I'm in the 110, 1% GDMT team because the hazard ratio is 1.4 versus 1.9, right? Again, 110 under low GDMT versus 95 under 100% GDMT. I would favor the blue one versus the red one. But so for sure, this is observational. We don't have trials testing, strategies, but still, I think this is convincing to some extent. So I've been working on low blood pressure for a while. So we published the first review in 2020 with a French group, then a simplified version in an editorial in 2021, sorry. But I wanted to push this further, and I'm very thankful to the HFA for actually publishing a document, and I will cover this later. But first, some additional thoughts. One, stopping diuretics is possible in chronic heart failure, and probably you should take advantage of this while managing low blood pressure. So this is a reminder for the REBIC trial. So a small trial, about 200 patients, where you would retrieve diuretics in patients with 40 to 80 milligrams of furosemide a day, and basically increasing the furosemide again only when you are compelled to do so. And actually, and this was a placebo-controlled trial, right? And you can see here that there was no huge difference in reintroducing diuretics, meaning that you can safely stop diuretics in this kind of patients with minimal differences in NT-proBNP actually. Second, additional, thinking point, please keep in mind that a large proportion of patients with low blood pressure have actually low blood volume. This is a clinical observation, and I will skip this actually because time is running low. But if you have a person with a low blood pressure with minimal IVC, so very low volume, probably you can safely stop diuretics and things will resolve. And I think it's a much better option than reducing GDMT. So this is the big piece, the big paper, the clinical management and therapeutic optimization of patients with FRF and low blood pressure from the HFA. I created something so that you can access to it directly. I will break down rapidly the different major figures that are within this document. First, no symptoms, SBP more than 80, don't bother modifying GDMT. Second, try to remove less important drugs, meaning drugs that are not associated with better survival. And typically heart failure drugs are associated with better outcome, but a bunch of other things are not associated with hard endpoints. So probably remove those before touching the GDMT treatment. Third, assess the link between low blood pressure and symptoms and whether this is something that is true outside of the hospital. And so we have put this table, tried to help physicians to take care of this kind of situation. So first, test for orthostatic hypotension. And if you have orthostatic hypotension, does it relate to symptoms? Because if it is not related to symptoms, then perhaps symptoms are related to something else. And if you do not have orthostatic hypotension, use ABPM to see, what's the blood pressure profile outside of hospital. And again, do you relate symptoms to low blood pressure on the ABPM? And then consider redo this if you find nothing, but don't jump on removing everything right away. So next step, For sure, if you have low blood pressure with a patient that is really not well, it may be cardiogenic shock, but it's just to push this aside from this story. If you have mild symptoms, probably it's better to do nothing, right? Having mild symptoms with maximum treatment that reduce majorly your risk of event is probably better than having no symptoms with a higher risk of death. And then, if you need to address this, we provide an algorithm to down titrate and re-optimize after, right? It's a touch and go approach. Don't down titrate forever. Okay, so another figure, the only thing that is truly important here is the breakdown of the drugs you may consider stopping before touching the FRF treatment. For instance, nitrates, antiarrhythmics, drugs for prostate, whatever, but try to get rid of things that are not related to outcome. And this is too complex for me to, go down the road of every scenarios, but the idea is to reduce one drug, but try to fix another problem if possible. If the patient has low eGFR, so perhaps you would decrease the drug that is related to both low blood pressure and low eGFR. Same for potassium. If the patient has decreased heart rate, so you may want to address both. And when you have an history of arrhythmia, then probably it's better to keep the beta blockers and try to decrease RASI first. But, this is a suggestion of patterns you may use to guide your down titration process. And for the acute part, I cannot go through everything, but the philosophy underlying this is keep in mind that GDMT is associated with lower neurohormonal involvement, and you need this to be relatively low if you want to decongest the patient. So keeping the RAS very high while you are decongesting is probably not a good idea. So it's better to keep at least some of GDMT pressure. This is the complex take-home messages we did in the paper, but my shorter take-home message is this one. If you can stay, and probably blood pressure is not that big of an issue. This is a maximalistic probably approach, but I would prefer stand up slowly than having a skyrocketing risk of dying. Decrease diuretics whenever you can, and how to manage low blood pressure is relatively difficult. So please refer to the HFA clinical consensus. Thank you.
Thank you. Thank you very much, especially for keeping the time. I'm very impressed so far. I didn't even have to cough. So now I'm very happy to introduce Professor Alexandre Mebassa from the University of Paris in France. And he will speak about how to secure a fast and safe initiation of GDMT in clinical practice.
Thank you. Thank you very much for this 20-minute lecture. And it's a joke. Thank you, Gianluigi, for the invitation. I'm going to try to focus on the safe and initiation of GDMT, but before I would like just to make sure that we are all agreeing that heart failure is a cancer, and what we are doing here is giving a chemotherapy for cancer. When we did STRONG, in fact, this is the concept we try to show, is giving all the drugs together very quickly will markedly improve outcome. And in fact, we succeeded, at least by explaining this concept of cancer and chemotherapy. We could convince the cardiologist to give within 3 months, 6 months, almost half of the patient had full dose. This is really important, full dose of the 3 pillars that were tested at the time. And you can see that MRA was even higher. And what is interesting is giving a full dose of chemotherapy translated in improvement in outcome, as you can see here, within almost 6 weeks, but clearly at 90 days and 180 days, there was a clear improvement in outcome. Now, after STRONG, many people were saying, yeah, but this is a special scenario. Then we did other studies to really convince the whole world that heart failure is a cancer and we need to give chemotherapy. And we were helped by ESC guidelines in 2023 saying that really when a patient comes with an acute heart failure, we should have an intensive strategy of initiation and rapid up titration before discharge and careful follow-up visits. And I will explain later how we are going to handle those follow-up visits. And the 2023 guidelines said we should start the 4 pillars at a full dose. And what is really interesting and new for us is not only we treated heart failure, but also it was one of the most powerful decongestion strategy to give the oral heart failure therapies. I'm going to show you 3 studies that just were published really in the last even weeks. This study was done in Tunisia, named the CD study. What we did, we took patients with preserved ejection fraction, because still people are saying, yeah, but STRONG was not powered for preserved ejection fraction. We did it for preserved ejection fraction. For safety concerns, instead of having the follow-up visit done by the nurses in the hospital, half of the visits were done at home. Nurses were going at home. And maybe as importantly, or more importantly, we looked on because patient is coming for dyspnea, we looked on the respiration parameters, respiration rate and SpO2. And this was really a big surprise for us, 90 days after starting the full optimization, we could see that respiration rate here at the left and oxygen saturation at the right, 90 days after admission for acute heart failure were better in the patients who had the STRONG procedure compared to those who did not have the STRONG procedure. And we could also confirm that at 90 days and 180 days, there were an improvement in readmission and death. Here at a more broader level, here it's a study that was published few months ago now. This is China, more than 600 centers that were accredited to do the STRONG procedure. A small cohort of more than 400,000 acute heart failure patients. I think you would be impressed. At least I was impressed when I had those database. And the primary objective was readmission and death. The analysis was done like this. We had the data before accreditation and the data 1 year, 2 years, and more than 2 years of accreditation. I would like just to focus on the primary endpoint, death and readmission. You see, and this is really incredible, and this could happen in any country. If politically it is decided to accredited center and teach them how to do the STRONG procedure, you see that within 12 months, we have an improvement in readmission and death. And you see that this is incremental. The more you are teaching the stakeholder, the more you are putting centers and more there is an improvement. And you see, by the way, that if you look only on the death, you see that death appears at year 2. Now, why this chemotherapy, why it is working in heart failure? And this is the paper from Jinjanuzzi and from Harvard. They show that few months after putting the full therapy, you can see not only a small improvement in ejection fraction, which is clinically significant, but I feel maybe more importantly, there is a reverse remodeling and there is a decrease in left ventricular size, a decrease in mitral regurgitation. Now, everybody's saying, okay, this is beautiful, but can we really do it? The answer is yes. Please just follow the guidelines. And in the guidelines, these are the recommendations. But if you read the guidelines, it's said for every follow-up visit, indeed, you need to try to do them as early as possible after discharge from acute heart failure. You need to do a comprehensive visit. And comprehensive visit is really easy. 3 clinical signs, 3 biological signs. The 3 clinical signs are symptoms and signs of congestion, blood pressure, and heart rate. Nothing more. Biological signs are NT-proBNP, potassium, and creatinine. And only by having these 6 signs, 3 clinical and 3 biological signs, you can really easily handle your fast and optimal GDMT. Now, conversely to what our colleagues may think, and this is what Gianluigi and Felix showed earlier, In fact, we had a little of hypotension, less than 10% of the patient had hypotension, very few bradycardia. But what we saw was a new congestion. In patients who are already congestive, if you add beta blocker specifically, you see new congestion. Let's look here on a patient who did very well. On the y-axis, you have NT-proBNP. When the patient comes to the hospital, you see that NT-proBNP goes down. And in fact, what is important is this point here, the NT-proBNP before discharge, crossing here the blue line and green line. You see that patients had a half of the dose of the 3 pillars. If at the visit week 2, NT-proBNP kept going down, then please, with no problem, you can go to full dose of beta blocker. In 1/3, 1/4, 1/3 of the cases, here again, having the NT-proBNP at discharge as really the important number to remember. We saw at week 2 that NT-proBNP went higher than even the level at discharge. And in that scenario, we paused beta blocker. And I think you heard it many times. Please never decrease and never stop those GDMT drugs. You should pause beta blocker, double the dose of diuretics, and in 96% of the cases, we saw NT-proBNP coming down. Then really, the main message is give the 4 pillars before discharge. It's very important for the patients to start to have the beneficial effect. It's like an oncologist who's giving chemotherapy as soon as the diagnosis of cancer is done, and try to see the patient as quickly as possible. And I hope I give you tricks to show that really it's very safe to give this chemotherapy. And if you would like to learn more, in a few days, HFA is going to do a webinar where we are going to enter into more details to explain the complex patients and how to handle them. Thank you very much.
Thank you.
Thank you. Thank you, Alexander. It was great. And I think we have a lot to discuss later on the implementation. I think that now we have kind of a switch before with Javed Butler, I think is online. Gianluigi suggested me to move with Javed. It's fine. Javed Butler. Oh, yes, as Gianluigi suggested. Javed, you are online, I think, right? Can you hear us? Javed? If he's not. Okay, so if Javed is not hearing us, probably.
No, I'm here. Sorry, I missed it. Is it my turn? I thought Marco was going first.
Yeah, Marco is after you.
Oh, okay. No problem. I will pull up my slides. Let me know if you see them.
Yep.
Okay. Can you see my slides?
Perfect. Yes, we do. Please, Javed. It's
okay.
Pleasure to introduce
Thank you very much. Okay, thank you. So my apologies first that I'm not there in person, but really appreciate the opportunity. I've been coming to this conference for several years now, and hopefully we'll see you all in person next year. So I will take some liberties here and change the topic from what Dr. Savarese gave me. So the topic that was given to me, is there any new GDMT to introduce challenging Digit, HF, and Victor? My disclosures are at the bottom of the slide, and I changed the title to Why Challenge Digit and Victor and Why Not Embrace? So let me make a point of embracing both the trials rather than challenging both the trials, and would be happy to then take some questions. So let's start with the Victor trial first. So as we know, the Victor trial did not meet its primary endpoint. The p-value was not significant. There was a 7% relative risk reduction in the primary endpoint of cardiovascular death or heart failure hospitalization. However, we are left with this result, which we have never seen in a heart failure study before. We have had several trials where both heart failure hospitalization and CV death were positive, We have many, many trials where heart failure hospitalization was positive but not CV death, but never the reverse, where we had a positive CV mortality but not heart failure hospitalization. The only exception to this is ICD trials, but they are obviously not heart failure therapy per se. So the question, and this result then translated into all-cause mortality benefit that was also statistically significant. So it all basically boils down to whether we believe in the mortality result or not. And if you do not hit the primary endpoint, should you ignore this signal? So I would first mention that this mortality did not come out of the blue. This was a hypothesis which was tested after the Victoria trial. Remember, in the Victoria trial, if you not include patients with advanced heart failure and you take those patients with the lower 3 NT-proBNP quartile, which was 5,300 or less, this was a paper published by Michele-Seni, showing about a 20% relative risk reduction in cardiovascular or all-cause mortality. In the Q&A, we can discuss whether it is fair to exclude the top quartile or not. But the bottom line is, when you look at continuous analysis, it went up to an NT-proBNP of 8,000. When you look at less than 6,000 NT-proBNP, you're seeing this mortality signal. This was actually part of the study design for the Victor trial. So Victor trial had two aims: not only to look at the extension of the benefit of vericiguat from worsening heart failure to all heart failure without worsening heart failure, but in the study design, based on that lesson, NT-proBNP was restricted to less than 6,000. So that was a prospectively designed study. And two, the trial was powered for cardiovascular mortality unconditional to the primary endpoint being positive. In other words, there was a 80% power regardless of what happens to the primary endpoint, and the trial was to continue till about 600 cardiovascular mortality events occurred. So this is not a chance finding. The study was designed both NT-proBNP and the primary endpoint. Now we can again discuss, well, if you wanted to see cardiovascular mortality, why wasn't cardiovascular mortality the primary endpoint? We can discuss that. But I just want to highlight that less than 6,000 was part of the study design and that it was powered for cardiovascular mortality regardless what happens to the primary endpoint. And then on top of that, in this very stable population, with half of them never having passed heart failure hospitalization and on medical therapy, which has been unmatched in any other clinical trial, including the use of ARNIs and SGLT2 inhibitor, whatever the mortality results we saw was on top of the best possible medical therapy that we have seen so far. Also, the results were internally consistent that the two components of cardiovascular death, sudden cardiac death and heart failure-related death, that account for, in HFrEF population, about 80% of the CV death, both were statistically significantly reduced, and both were reduced to a magnitude which I think all of us would consider clinically meaningful. 25% reduction in sudden cardiac death, which was seen. The curve started separating at about 4 months and became statistically significant at about 5.4 months. And about a close to 30%, a 29% relative risk reduction in heart failure-related death. Now, again, I only have 10 minutes, so I don't have enough time to discuss the other thing. We can discuss that maybe in the Q&A of why wasn't the hospitalization benefit seen. We have seen over the trials that more and more care is being given in the outpatient setting. There's a whole another academic discussion which is occurring about outpatient worsening heart failure. We saw that in Paradigm trial, it was less than a quarter of the patient, about 50-50 in the SGLT2 inhibitor trial. And in the Victor trial, it kind of reversed, and 60% of the events were in the outpatient setting in these stable patients. These outpatient events were associated with high risk of mortality, and if you include them in the definition, you start seeing a statistically significant benefit. Again, happy to discuss this in the Q&A session. So now let's move on to the DIGIT-HF trial. This trial was looking at digoxin in the modern era of medical therapy. Original trial was designed for over 2,000 patients with enrollment and other issues, eventually ended up with about 1,200 patients overall. Was followed longitudinally for clinical endpoints. There were two strata of enrollment, either EF less than 30%, or if you're between 30 and 40%, then you need to have advanced class 3, class 4 symptoms. And that's what the trial primarily enrolled, was advanced heart failure symptomatic patients. In terms of the baseline medical therapy, again, very good baseline medical therapy like the Victor trial. The only exception was that SGLT2 inhibitor use, because of the temporal changes in SGLT2 inhibitor use, was very low, about 19%. And SGLT2 inhibitor obviously has the same interaction with the primary endpoint of this trial. So that is the only thing that raises the question about the results if the SGLT2 inhibitor level was high. This trial also was positive, statistically significant. The primary endpoint, all-cause death or first heart failure hospitalization, there was an 18% relative risk reduction, which was statistically significant. If you look at the two components of the primary endpoint, neither of them were statistically significant, but the magnitude was almost the same as the primary endpoint, and I would assume that a large part of it was related to the lower number of events because of the small sample size, not necessarily the benefit. Even this merging of the curves that we see towards the end is likely because of the fewer patients, fewer follow-up, fewer data, those sort of things. So they looked at a whole variety of secondary endpoints, and there are two ways of looking at these data. None of these secondary endpoints, like sudden cardiac death, death from non-cardiovascular causes, other combinations of endpoints, reach statistically significant. But I would suggest that most likely this is because of not having adequate power overall. So the question is, where do we go from here now that we have these two trials? And the fundamental question is that every single heart failure paper, every single presentation starts with the epidemiology of heart failure. And do we believe in what we say when we present those data? We all say that heart failure has as bad a mortality as many forms of cancer or worse, that the 5-year mortality for these patients is close to 50% or so, regardless of EF. And in the HFrEF population, despite quadruple therapy, you have a residual risk of about 1 in 5 to 6 people dying or getting hospitalized within 1 year. So yes, we have come a long way with the quadruple therapy, but there is substantial residual risk in these patients. And this is the network meta-analysis by Adrian Woers and Jesper Trump and their group, showing that addition of further medication leads to significant reduction in the risk of mortality. So at least the way that I am seeing it is that for vericiguat, if the patient is intolerant or contraindicated to one of the 4 GDMT, then I think it's a no-brainer that it should be added. If a person is unable to take at least 50% of the doses because of creatinine, potassium, blood pressure, whatever, they are on really minuscule doses, then I think it also makes sense. The fundamental question is, what if the patient is not intolerant to anything? They can take the 4 medications, and that's where this issue comes up, whether the community believe in the mortality results or not, both in terms of the residual risk for mortality and in terms of the study design and the way it was designed, even if you did not meet the primary endpoint. And for digoxin, yes, there is this issue of a smaller trial, fewer events, and the fact that SGLT2 inhibitor use was low. On the other hand, however, we have seen that in the previous DITCH trial also, and we are seeing now as well, that at least in my mind, if you give all the therapies and people have persistent advanced symptoms despite optimal medical therapy, then it makes sense. And I will end my presentation with one last question, and that is that just suppose if you lived in the opposite world, suppose if the Victor trial was not designed for mortality result, and suppose it hit the primary endpoint, was significantly showing reduction in hospitalization rate, quality of life improvement, everything, but there was a higher risk for mortality. Would we be willing to ignore mortality? So benefit in mortality and risk of mortality are two sides of the same coin. And maybe that's one way to think about it as well. Thank you very much.
Thank you so much. Introducing 2 more novel drugs, leaving us even more confused than we were before. We will now welcome Marco Metra, who will talk about the available weapons in worsening heart failure, which will be the last talk of this session.
Thank you, Camilla. Thank you, all the board. Pleasure to see also Ricardo on the podium. So that's a legacy that's continuing. And thanks to Gianluigi for his invitation here. My presentation was meant to be before the JAVED one. And just to say that Victor is what happens when you select patients who didn't have a worsening heart failure event or an heart failure hospitalization in the previous year. It's surely a kind of different patient population from what we were looking at talking about heart failure. Let's see if I can, these are my disclosures. So worsening heart failure. Worsening heart failure this is one of the slides that are most often shown in my knowledge, talking about heart failure. This is the trajectory of the patients with heart failure. And this is the trajectory of the patients with heart failure, and this is worsening heart failure, an event that is landmark in the clinical course of heart failure. It occurs in patients with a chronic heart failure, already a diagnosis. It must be kept different from early onset, new onset heart failure. And it generally marks a turning point in the clinical history of the patient, because we know that when it occurs, the patients are going to have a poor outcome. This is taken from the first universal definition of heart failure. Birkem knows much more than me. And we know that also in the first universal definition, it will remain also in the next one, we had these stages in heart failure, and we also had worsening heart failure as an event that marks the stage C heart failure and moving towards advanced heart failure. But worsening heart failure is also a red flag, as I said, a time in the course of the patient when we have to focus on the patient, learn that it is going to have a poor outcome, and optimize medical treatment as much as we can, and potentially refer the patient to a tertiary care center if necessary. Because of this, also in Europe, and with the help of Giuseppe, we wrote this paper as a Heart Failure Association on worsening heart failure. It came a few months later than the US articles, so it's a pity for us, but we outlined the characteristics of the patients with worsening heart failure. And I can clearly say that Giuseppe Rosano was the one that recommended to me this figure with a broader definition of worsening heart failure, not only the hospitalization, and this will be the main topic of my next slides, not only the hospitalization, but also a clinical event that can be characterized by new signs of congestion or even a decrease in exercise capacity. We may have a subclinical worsening heart failure, just shown by invasive hemodynamic monitoring. Let's think about a patient with a CardioMEM, but also imaging, or even better, biomarkers. An increase in NT-proBNP plasma concentrations may be a marker of worsening heart failure. And then we have the events and then the outcome.
This was the first analysis by Scott Solomon showing in CHARM, candesartan in patients with chronic heart failure, that when the patient was hospitalized, he had, compared to the outpatient, an increase in mortality that was from 4-fold to 16-fold. And so it started the paradigm of hospitalization equal to worsening heart failure, which is not true. And Javed has shown this, and I will come back to this. But this hospitalization is true, is correct. This is the analysis of the Euro ESC heart failure long-term registry led by Lars, and showing very simply that hospitalized patients had a increased mortality and heart failure hospitalization rate compared to outpatients. But then, as I said, we have to broaden the definition, and worsening heart failure includes also an unplanned visit to the emergency department because of breathlessness of the patients or signs of congestion, and includes also an unplanned outpatient visit where the patient says to us that he feels poorly, it has he has increased symptoms, and we detect signs of congestion and increase diuretic therapy, even oral diuretic therapy. How hospitalization can change was dramatically shown, but this is quite clear, by the COVID-19 pandemic. During the COVID-19 pandemic, these are the data from the London area, there was a dramatic decline in the number of hospitalizations compared to the previous year, despite an increased mortality. And then we have a retrospective analysis of randomized control trials showing the same. We have this from Paradigm-HF, and you see that patients hospitalized for heart failure have a 5-6-fold increase in the number of events, but also the patients who had an emergency department visit for heart failure, or just the patient who had an intensification of oral diuretic treatment, they have a 4 to 5-fold increase in the event rate. Sorry, I don't see how much time I have, and I don't want to create problems. 3 minutes. And this is registry data, just outpatient intensification of diuretic therapy is followed by an increase in the event rate. And again, also these heart failure events are affected by guidelines-directed medical treatment. You see this from the Emperor Preserved trial, that the empagliflozin reduced not only the primary event, but recurrent hospitalizations and also outpatient intensification of diuretic treatment. And you have already seen this from the Victor trial, showing how the epidemiology, the clinical presentation of heart failure has changed in these last years. And there has been a progressive decrease in the number of heart failure events leading to an hospitalization compared to Paradigm-HF, and a progressive increase in the outpatient events that now include 75% of the cases. And this is what Victor has shown, that if you just look at hospitalizations, you lose the effect of therapy. But if you have a broader definition of heart failure events, including outpatient intensification of diuretic treatment, you have a drug effect. So watch out for the next trials. Then we have signs of congestion as clinical signs of worsening heart failure. And we have a treatment that now, more than before, must include 5 pillars of drugs. So that not only neurohormonal modulators and antagonists for patients with FREF, not only SGLT2 inhibitors for all patients. Let's recall iron supplementation if the patient has iron deficiency, as shown in AFFIRM-HF, but also vericiguat in a patient with reduced ejection fraction, as shown in both Victoria and in the meta-analysis, to be effective in reducing heart failure rehospitalizations and more cardiovascular mortality. And again, the benefit, this has been already shown by Javed Butler, the benefits of quintuple therapy and the benefits of additive therapy. So my take-home messages are these: worsening heart failure characterizes the natural history of heart failure. It includes heart failure hospitalizations, emergency visits, and outpatient visits with a diuretic escalation. It is caused by congestion. It can be prevented by early detection of congestion, and its treatment and prevention pose a unique challenge with the need of optimization of medical therapy, including vericiguat. Thank you for your attention.
So thank you very much for this excellent talk. We now welcome all speakers on stage. And we will have a discussion of what we've just heard. All the questions from the floor are welcome. Please go to the microphones.
If no comments, I will start and taking the opportunity to discuss further about the concept of including worsening heart failure event in our composite endpoint of design and clinical trial. And I will actually like to ask to Javed, we've been discussing a lot, especially in the last period of time, about the implication of oral diuretic intensification as a endpoint to include or not in the design of a clinical trial. And we recently have an interesting kind of sort of editorial of Review on New England Journal of Evidence about the concept of what is exactly oral intensification, and if we should include it in the endpoint of future clinical trials, and in what kind of population you should use it.
Yeah, so it's a little bit of a difficult question to answer because can you hear me? Yeah.
Yes, we do.
The reason it's a difficult question to answer is that remember that there is a degree of uncertainty with any endpoint that you have. For heart failure hospitalization, there's a lot of uncertainty, right? We know that heart failure hospitalization reflects both the severity of the disease, but the local practice patterns, the number of hospital beds available in a community, all those things happen. But we as a scientific community, as an academic community, as a clinical community have accepted that degree of variation, and we include heart failure hospitalization as an endpoint because majority of them are associated with poor outcomes, but not all. We then had this whole robust discussion about IV diuretic in the outpatient setting. We had a lot of concerns that what if the patients are just inappropriately given IV diuretics because there may be some other incentives or whatever. We went back and forth and we created that. Now we are going through the same thing with oral diuretic intensification. So there are three categories, right? So if somebody is not on a diuretic, they're started on a diuretic. If they are on a diuretic, their dose goes up. And I don't know what these bubbles are. Sorry about that. And then the third is that if they are on higher doses of diuretic, a second diuretic is added. So all three of them are diuretic intensification. The struggle here, and the data are very clear that oral diuretic intensification is associated with poor outcomes. What is unclear is that how long it should be going up for, because it's very common practice for people to go up on a diuretic for 1 or 2 days if they gain weight. Whether it should be associated with worsening symptoms or not, and those kind of things that the academic community will have to work through. And then the last comment that I will make is that there is a fear that if you have oral diuretic intensification as part of the primary endpoint, then all of a sudden it will be 50-60% of the primary endpoint. And now your hospitalization rates will be even low, mortality rates will be even low because of all of this outpatient oral diuretic. And if you win, will the payers and will the clinical community buy it as an endpoint? So this is a, sorry, very long-winded answer. That's a really important topic, and we should try to come up to a conclusion as an academic community. What are we going to do with it?
Please, Marco.
If I can add something. First of all, as you said, it's very important, and having registries like SWID-HF is very important to look at sensitivity of this event with respect of the outcome of the patients. So it may be that 1 day of intensification of oral diuretic treatment is just having eaten pizza the night before, and the patient can deal with 1 day of increase in Lasix, or it may be that even this is attended by a poorer outcome. So we need more analysis of registries with respect to this endpoint. But the other thing is that it seems to me that the regulatory bodies, including FDA, do not accept, and you know, Javed, these do not accept this intensification of outpatient oral diuretic as an endpoint for a clinical trial and for approval. And so it would be important to have a meeting with these regulatory agencies to sensitize them, because, I mean, Victor has dramatically shown that this outpatient worsening heart failure event may make you lose the efficacy of a drug. So we need to sensitize regulatory bodies, I think, like we did years ago.
Lars, welcome.
Yeah, thank you very much. So going from trial design to clinical practice and unmet needs. So HFrEF stage C, enormous success. HFpEF moving in the field of metabolism adiposity, leaving, as I see it, the biggest unmet need, this worsening / advanced / C2D heart failure. And this is not really just including hospitalized patients in trials like in MPulse, because they are stabilized in hospital. What about those that are really not stabilized or truly progressing or really advanced? Marco, what is the physiology that should be targeted? Is it congestion? Is it contractility? Is it perhaps vasopressors? What's the next strategy looking over the next 10, 15 years in targeting this population where other trials have been not successful?
Okay. Thank you, Lars. You know what I answer. I cannot not think that myocardial contractility at some point becomes the limiting factor. In my mind, it's very easy, because if the patient develops hypotension, meaning a systolic blood pressure less than 110, this is low cardiac output in the end for this patient. And so I think that a treatment working on the cardiac function should be effective. And the DIGIT-HF trial has clearly shown that even in nowadays there is room for improvement with this kind of treatment. Of course, it's difficult to demonstrate because, and it's the case of galactic HF. If you include patients up to 35% of ejection fraction, no matter what systolic blood pressure, so we had patients with 140 of systolic blood pressure. These patients do not need any improvement in cardiac function. So the trial must be targeted at the right population, but I think there is an unmet need for sure. Okay, good to see beer chemos, not vasodilators in this case.
We would also like to welcome our friends who sit in India, Professor Agrawal. How is it going for you?
Great. I think I've heard some great talks and lots to learn and discuss. Yeah.
Okay, so we'll take it. Oh, sorry.
I would actually, I think I just had a few comments to make regarding the talks. And one of the things which we, sort of lose sight of a forest for a tree is we don't really give too much importance to the role of cardiac rehab. And, with all the same drugs which the patient has on board, a patient who walks, who exercises regularly, who is under supervised cardiac rehab tend to do much better in the long run as compared to somebody who doesn't. That's number one point which I wanted to raise. The other is that we are underutilizing cardiopulmonary exercise testing as both a diagnostic test and as a prognostic marker. And I think that's something which should also be put on sort of as a priority for assessing these patients of heart failure in the long run. Because I think we underestimate the role of muscle in the outcomes. And that's one thing which is missing out in most of the trials is the effect of sarcopenia, the muscle mass, the exercise, which is, I think, very important in the overall prognosis of a patient of heart failure.
Thank you very much. We have another question here from the floor. Could you please state your name and where you're working?
Okay, thank you, everybody. My name is Lavin F. Judge. I'm working in St. Kyoran, Apia St. Kyoran. My question is about implementation of GDMT. Felix talked about getting access to a dedicated heart failure unit is an advantage. And James was talking about access to specialist advice and knowledge, not clinic, because that will increase the confidence for using the GMDT. So my question is, how do we improve access to information for the primary healthcare? Because they receive a large number of patients that have heart failure. It's a general question to everybody. So.
If I may start, your point is extremely well taken. I think that's a very important thing. And we should take advantage of, for example, the very good electronic health record system we have in Sweden, which facilitates very much communication across different clinics. And I think we don't do that enough. We just use the referral system just to refer patients, but actually that could be also a very good way for you to get advice from more specialized settings and actually start to work on specific subgroups of patients directly in your clinic while the patient is referred to others. So that's how also the knowledge can be transferred across different clinics, and I think that will facilitate as well the work at different levels in primary care as well, where these patients are seen first, for then, in the meanwhile that they get referred to secondary care, where the waiting list is sometimes extremely long.
Yeah, thank you for the question, and I agree with Gianluigi. I think that with the increasing complexity of heart failure treatments, I think it's very difficult to expect that primary care, who deal with many patients with heart failure, but at the same time, heart failure is a very small proportion of their practice. And I think it's really essential to to realize what we expect. And I think the focus should be on recognizing appropriate times for referral rather than trying to disseminate the knowledge to the primary care for them to manage everything with the support for cardiology. I think the study that James presented on the virtual consultations for nephrology clinics or for primary care centers who were having access to such a service, increasing the use of finerenone is a very interesting approach. And I think that might be sort of a hybrid approach that might be appropriate in some scenarios as well.
I'm just gonna say, I guess we're living in a time when earlier recognition of symptoms and earlier treatment and leading to prevention of disease and symptoms is really important, and the role that primary care play within that. From a CKD point of view, that's more acute, but even from a heart failure perspective, we need to recognize that people will see primary care and they will be altering doses of medications and changing GDMT. They will be down titrating RASI therapies in the context of hyperkalemia. Primary care have a really significant role in ensuring that people continue on their GDMT. And so I guess from my perspective, there's a couple of things. We have to make things really simple. We have to make the messaging incredibly simple. The second thing is we all need to do the same thing, because if we don't do that, then primary care just don't know what to do. If they get conflicting messages, that is incredibly difficult. And the third thing is that we found really key is not to go to primary care and say, this is how primary care should manage CKD or heart failure, but ask primary care how they need us to help them to do it themselves. And that is really key, because that empowers and activates primary care, and it actually, more importantly, will generally involve the patient in that and will keep them adherent to their medications.
Thank you. Nicolas, and then Baikem.
Very quick add-on. We have published an analysis this year in European Heart Journal on all heart failure patients in France that the social security know of. So patients admitted for heart failure or under long-term heart failure status within the healthcare system. And so 700,000 patients, so 45% have not seen a cardiologist in the year before identifying them, right? So basically 1 in 2. So the great divide is paramount. Only 1 in 2 see cardiologists.
Baikem, please.
Hi, Bikram Baskert. I want to comment on the most final concept, but also in the stage C to D. Yes, we will all be treating different diseases with similar medications for the different proximate cause, even though the clustering of the risk is going to be very similar, because everybody eventually develops the cardio-kidney metabolic profile. Having said that, I think the standardization and multiple medications now are with rapidly expanding indications will probably eventually make the framework simpler. My comment was the concept of C to D, which is a critical component for us to recognize, is a trajectory of the patient at the patient level. We're looking at the trials at population level and or the trial population level, but at the individual level, 2/3 of the patients after initiation of GDMT improve. What happens to the rest is the story, and we've always assumed the one that is very advanced, stage D, is less than 1%, i.e. that was defined by the requirement for VAD and transplant, so that was limited to the availability of the advanced therapies. Therefore, we always kept it in that little container of less than 1% of the patients are D. In essence, what percentage is actually not improving? If you look at the mortality rates at 1 year, in the best scenario for stage C is 10%, 1 year. Sicker is 25%, the sickest is 50%, 1 year mortality. And therefore, and they're not dying, the majority of them are not dying from sudden cardiac death. What are these people dying from is progressive heart failure. And how do we define that? Is that trajectory, and thus it's going to be critical, like cancer did. How are we going to identify progression of disease? The way I see it is, if you're not totally becoming asymptomatic and resolved, and if you're with persistent symptoms, you have active cancer. And that requires further optimization. If you're worsening, my goodness, that requires referral and really important concepts for which we do not have targeted therapies for. And that's an area of gap. And yes, Digitalis, ongoing studies with maybe cardiac myosin activators and others, there's not a good phenotypic targeted therapies there. Majority, if lucky enough to respond to GDMT, will improve. But then what happens if they're unable to tolerate is the key. And this is not a small population. If you were to say 10% of stage C in the US, that's 500,000.
With this respect to the trajectory, I think a major problem remains for our failure that we don't have a measurement. I mean, we don't have like incretins, we have body weight, and in addition to everything, I mean, kilos are very easy to measure. We had blood pressure, total cholesterol. I think we must emphasize more the role of serial NT-proBNP measurements, because I mean, to me, is the best parameter that we have. And if we measure them systematically, first for the early diagnosis of heart failure, first, because, I mean, we measure serum creatinine. Think about serum creatinine. What did it do for chronic kidney disease? And what we have for heart failure and cardiac dysfunction is probably NT-proBNP. First for the early diagnosis, but then also to follow the progression of the syndrome and have, again, a threshold. And this is my guess.
Marco, I would propose maybe a whole portfolio that the clinicians already are using in the following: hospitalization, you're worsening. ICD shocks, you're worsening. Unable to tolerate meds, you're worsening. Blood pressure is going down, you're worsening. We know what those are. I think we could give the discretion to the clinician to say, you're worsening, you're better. I know in the clinical trial realm, we'll need to come up with objective criteria. So I would look at the trial concept separately than the clinical practice. Progression-free survival in cancer relies not solely on symptoms and the tumor burden and the biomarkers. It's a constellation of all. I think we're going to get there in terms of the progression-free survival concept for trials. But for the time being, for the clinician to say, I don't think we should say you're stable because you're dying. That's what it means. If they're still symptomatic, I think the concept of is this improved and recovered or resolution of symptoms, I think we need to get to that resolution of symptoms, especially for the one that is with good functional capacity, along with the ventricle looking better, biomarkers looking better, and the rest, and that you're not getting hospitalized in between.
Welcome.
Tashi, I work at the South Hospital in the city here. My question is, in order to implement GDMT, we have these two parameters, blood pressure and CKD becoming a sort of a hinder. My question is, what is the evidence that we can go beyond the need to monitor blood pressure for the asymptomatic patients? Because, and the other thing is that the need to monitor GFR or creatinine, because the kidney doctor already said that the heart failure medication is good for the heart failure survival and does not seem to damage so much. And the hyperkalemia is a handleable situation with a lot of new kalium binders, so potassium binders. So what is the evidence? Can we go ahead having to need to monitor blood pressure and creatinine so that we can improve the implementation?
Nicholas, do you want to start?
I take the first part on blood pressure. we're probably monitoring it way too much. Yeah, let's have not that frequent look to blood pressure and will be less of a problem because then you have the nurses freaking out and the patient being, you know, obsessed with it and measuring it all the time. So actually, I am arguing against using blood pressure monitoring within telemonitoring in France in the system that we have because of that, because it will create problems and actually not that much solutions. So I do agree with that for blood pressure.
From a creatinine point of view, I'm going to go with what Nicholas said, to be honest with you, for the same reasons. And I think also if the diagnosis is not in doubt, why do we measure GFR? Why do we measure creatinine? We measure it in case we need to change medication doses. I guess that's fair. We measure it for potassium, which isn't about their GFR, and that is also fair. And we measure it to educate patients and prepare them potentially for dialysis. And controversially, I'm going to say in the group of people who have worsening creatinine because of their heart failure, is that, well, that is a conversation we need to have, but potentially those people are not necessarily the best dialysis candidates because we know that actually we will probably not increase their quality of life, and any years of life gained will be the time they spend attached to a dialysis machine. So we should be monitoring it less, actually. And in certain circumstances, so for example, I look after a lot of dialysis patients, and I'm often asked about the evidence for beta blockers and Entresto for dialysis patients and their outcome for heart failure. And I'll point you back to what I said earlier, which is we should be treating everybody with CKD the same as we should be for those who don't. And I would say that is true for dialysis patients. But actually, those with more advanced kidney disease, if you check the creatinine, the knee-jerk reaction is to down titrate or to pull back on the treatments for heart failure, which may not be the right course of action, I'm sure. And from a kidney lens, I would say that we have a similar thing about blood pressure. There's always that worry of treating the number rather than the person, because to a nephrologist, a systolic blood pressure of 90 in someone with heart failure and CKD, we might be thinking, oh, we need to reduce the Entresto because it's the number that worries us. But actually, I now know, because I work much more closely with my heart failure colleagues, that if they're not symptomatic, then actually those medications are really good. So again, I come back to that idea of really talking to each other about it.
Lars?
I would nuance that just a little bit. I mean, I do encourage measuring blood pressure and GFR. And in fact, like Alex would probably say that too, because that's what enabled you to uptitrate so rapidly in strong HF, right? So do not only think of them as barriers to treatment, think of them as tools to increasing and improving treatment too. The problem is not that we measure it. The problem is that we overreact to it. So the key is that it's the clinical context and not the number. That's exactly right. But you also need it to be aggressive.
Can I make one point?
Yeah, of course.
So, you know, I'm the nephrologist in the room, so I need to say this thing, is measuring ACR can be a really, really great tool in this, actually, because every single medication that we are talking about at the moment will cause a rise in creatinine and a reduction in GFR. And people will look at that on their apps and say, that medication is harming my kidneys. But if we do a regular ACR for SGLT2 inhibitors, for MRAs, for finerenone, you'll see a reduction in ACR, and you can say to the patient, well, actually it isn't, because this is a more sensitive marker of scarring and damage, and you can show them an improvement in their ACR. So that's my slight plug that we should all be doing more ACR.
And can I make a comment? Can I make a comment?
Please go ahead.
Yeah. So, you know, if we take a scenario where the patient's creatinine is going up, the GFR is falling, and there is also a blood pressure which is, say, around between 80 to 90 systolic. Now, I think that we will have to define permissible hypocreatinemia in most of these patients. If the patient is hypoperfusing and the creatinine is rising up when you're adding new drugs, I think that's the problem of deciding whether to continue or to withdraw. And I think most of us are quite comfortable if the blood pressure is, say, above 100, 110, But it's when it is borderline is when you will have trouble deciding whether you would want to continue with the ARNIs or withdraw them at that point of time.
So I can, and that's absolutely right. But ultimately, you know, our patients will die of their cardiovascular disease before they need dialysis. And so the key here is to keep them out of hospital for their heart failure, because the more we've seen very beautifully in a lot of the talks that, you know, that worsening of heart failure and that point where they start to come into hospital more often, that is where they are at risk. And so it is a balance, but generally speaking, you know, we need to react less. I think that was a really lovely turn of phrase, react less to the creatinine and think more about getting that person comfortable and keep them out of hospital by managing their heart failure.
Very short follow-up, and I do agree with Lars that in expert hands, it's very nice having the blood pressure, and even more so when you up titrate, not that much for down titration, right? But for up titration to see how much you can up titrate. For this, I agree. It's very important.
Probably Alex was going to say something.
Yeah, I would like to be even more provocative and say maybe we should not see the patient anymore. And in fact, we should make a difference between the up titration, where we should see them very, very often and measure what is needed. But I'm working with many centers now all around the world to say in the 50% of the patients who are really fully treated with full, I mean, the 4 pillars at a full drug, we decided, and I hope within 1 or 2 years we'll have the data, we decided to not see them before 1 year, even sometimes 18 months. Indeed, if they have a problem, they will call, and then we will see whether going up to 12 to 18 months, whether it makes any difference. And I think this will make a big change because it will give more rooms to our heart failure clinics. The patient is less anxious. And again, if they're fully treated, the question is, should we even see them again?
That's a good point. Bikem?
I fully agree with that comment on sometimes we treat the numbers rather than the patient, and the concepts probably we need to start formulating is, yes, hyperperfusion is the one that we're dancing around, you know, blood pressure and the end organ damage, and maybe we need to clearly, as Dr. Agrawal pointed out, the Achilles heel is the shock, the pre-shock, and the hyperperfusion. And as once and if, you know, the patient self-declares and or we diagnose the patient, the question is, you know, in what percentage of those will be able to continue or not. That's an art. I'm not going to go and mention that. The rest is okay, except for when we're coming to that eGFR of less than 25, which requires the help of our nephrologist. Now, the problem that I see is this, at least in the United States, the system is formulated and incentivized monetarily to stop care because the diagnostic related grouping of ICD-10 codes are enriched with AKI, acute kidney injury. In the US, if you code AKI for a hospitalized patient, the reimbursement is more. But you cannot get paid unless you do something for AKI. Whenever you code something, you have to do something. And if you are not doing something, you don't get paid. Hypoxia, you give oxygen. AKI, what do? Stop therapy. That's what all the hospitals, all of the administrators and the trainees are told to do. This is a problem, and it started with the AKI definition, which we now need to intervene on. AKI, I was mentioning this in some other forums, is the highest rising diagnosis in the world, not in the US only, everywhere. It's next to sepsis for all of the hospitalizations worldwide, and it increases like this. It's almost like an epidemic of something. Nephrologists agree with us saying we shouldn't be coding, this is not AKI, but regardless of that, any rise, we're not talking 0.3 increase, 0.1 increase is coded as AKI because it makes it look more complex. For the outpatients, it also helps with the complexity of care and reimbursement. For that reason, we'll need to come up with KDIGO and others. In this setting, you cannot code AKI. ban it. Otherwise, it's going to continue.
Thank you. Frieder, a short comment,
Yes, it's only
which
a
will be the
comment.
last one.
I just noted that we are a group of highly specialized academic center cardiologists or nephrologist or hypertension specialist. And as Felix mentioned in his first talk, highly predictive variable, which patient had a better prognosis, were those cared by specialty care, but as a matter of fact, significant proportion, or in Sweden, the majority of our patients is treated in primary care. And these are, as you know, older, more polymorbid, have maybe some kind of cognitive dysfunction and even more difficult to treat. So I think it's very important to seek this communication with primary care, maybe to invite them to meetings like this. And these simple messages like tolerate GFR increase, low blood pressure, high potassium is very important really to communicate with primary care. And we should be even better in seeking this collaboration.
Thank you very much for this very nice comment at the end. There's a lot more to discuss, and we have now the opportunity to do that over a cup of coffee, which is served here right to the left. And even thank you to all the speakers, great talks, but there's a lot of issues to be solved. Thank you also to our friends who are here online. And the next session starts at 3:10, treating cardiorenal metabolic disease. Thank you.